Good afternoon, everyone. This is Maureen Hensley-Quinn, Senior Program Director at the National Academy for State Health Policy, and I'd like to welcome you for joining this webinar, How Would a State Individual Insurance Mandate Work? It is brought to you through the support of the Robert Wood Johnson Foundation. As you likely know, the tax reform law enacted in late 2017 included a provision that eliminated the penalty for not having credible insurance coverage that was put in place through the ACA, or the Affordable Care Act. The ACA's federal insurance mandate was viewed as an important tool for encouraging people, especially those who are healthy, to purchase coverage, which helps to balance the risk pools within the insurance market. Without a way to enforce the ACA's federal mandate, there has been a growing interest among states to better understand and explore state-level alternatives, including a state mandate. So today, we have both state officials and national experts to talk through some of these options. I'd like to introduce our speakers, and so next slide, please. I'm not going to go over in great detail each of these very short bios, but I would like to introduce you to Audrey Morse-Gastier, Chief of Policy and Strategy at the Massachusetts Health Connector. She is joined by Ed D'Angelo, General Counsel at the Massachusetts Health Connector, and Marissa Waltman, Director of Policy and Applied Research, also at the Massachusetts Health Connector. Then we will hear from Stan Dorn, who is a Senior Fellow at Families USA. And then finally, Jason Levitis, Senior Fellow at the Yale Law School's Solomon Center for Health Law and Policy. We are truly grateful for their time that they took to prepare for this, for the time that they're taking to be here today. We are planning to go through their presentations in total before opening it up to the audience for you all to ask questions. However, we encourage you to ask your questions as they occur to you. You have the ability to ask questions through the chat function that you will see on your screen. I believe it's in the lower left hand. It may be a little box, but you can click on that, write your questions as they occur to you, and we as staff here at NASHP will be going through them so that we can verbally share the questions with all the speakers at the end of their presentations. We will do our best to get through all of your questions. Let me also just note, because this is a popular question, we do plan on posting all of the slides that you'll see today, as well as a recording of this webinar so that you can refer back to it. It will be posted within 48 hours or so on our website. And with that, I believe I'm just going to move us to the next slide and introduce you to the Massachusetts team who will be sharing Massachusetts experience with a state individual mandate. Audrey?
Great. Thank you so much. This is Audrey Gastier from the Massachusetts Health Connector, and before we dive in, I just want to thank Trish and Maureen and Christina at NASHP for their leadership in coordinating this conversation, which we've been really looking forward to, and also thank Stan and Jason as well, who we've really enjoyed working with and talking about these issues with, and we've learned a lot from. So diving right into the next slide. At a very high level, what we hope to do in our brief remarks today is give a little bit of a background and overview of the Massachusetts Individual Mandate, which, as many on the webinar may know, has been in existence for over a decade here in Massachusetts, as it was included as part of our health reform initiative, which was passed into law in 2006. There were a number of different reforms that were a part of that coverage expansion law and effort, one of which was the individual mandate itself. In Massachusetts, the mandate is really designed and implemented and administered by the Health Connector, which sets a lot of the policies that make up the mandate, and is effectuated and administered through the Department of Revenue through the tax process here in Massachusetts. The mandate went into effect on July 1st in 2007, and that was accompanied by a major public awareness campaign and outreach efforts to make sure people in the state understood what was changing. It has been very effective in our state, along with a lot of other policy and program tools, which we can talk about. In 2015, which is the most recent tax year for which we have data about compliance with the individual mandate, only 3% of adult tax filers were not carrying coverage that met state standards, which we'll describe. The mandate itself is comprised of three core policy components. One is coverage standards, which really dictates what the nature of the coverage needs to be in order to count as coverage under the mandate. It also includes, secondly, affordability standards via an affordability schedule, which determines what people are expected to pay towards health insurance coverage, above which point they would not be penalized for not carrying it. And finally, penalties and exemptions. So we'll walk briefly through each of those three components, and then finally we'll wrap up with some thoughts about, in addition to some of the obvious benefits of an individual mandate at a state level with respect to risk pools and encouraging coverage, some of the other secondary benefits that we've identified in our over a decade of having a mandate here in the Commonwealth. So with that, I'll hand it over to Ed D'Angelo for the next slide, which is on our coverage standards here in Massachusetts.
Right. So we have minimum coverage standards because we want people to get insurance in order to satisfy the mandate, and we want the insurance to have, some minimum standards. They just can't come up with like a cancer-only policy or some other very limited policy. So there are basically three aspects to the minimum coverage standard. Some plans are deemed per se to be to meet the standards in Medicare, Medicaid, the qualified health plans that we sell. If you're not and noteworthy that unlike the federal standards, we don't per se qualify every employer health plan. So the employer health plans, just like individual health plans, would have to meet the substantive standards. So the substantive standards have two features. They deal with covered benefits, so we require a coverage of a broad range of benefits, very similar to the essential health benefits that were required under the ACA, and worth noting that our standards date back from pre-ACA, so there is some overlap. Our standards provide limits on cost sharing, so we have a cap on annual deductibles, we have a cap on maximum out-of-pocket spending. We don't permit. We have a cap on limits for. We have actually a prohibition on limits for coverage, and if a plan doesn't meet those standards, so if there's a variation, for instance, our cap on deductibles is $2,000, $4,000, individual family. If a plan varies from that, it can still be waived in, or it can get a waiver. If it can show us that its actuarial value of the plan is at least the same as the lowest actuarial value of a plan that we sell, so that's 60% because it's bronze. And so we have a fairly regular process of certifying plans on that standard.
Great. So moving on to the second pillar of individual mandate policy, we have the Affordability Schedule, which is a tool that a resident can use to help determine whether or not they'll owe a penalty for failing to enroll in coverage. Each year, the Health Connector's Board of Directors sets a percentage of income that it determines is reasonable for a household to spend on health insurance. And if the family has access to insurance meeting those MCC standards at a price within that reasonable range, but they fail to enroll, they would owe a penalty. So if the coverage available to them would cost more than what's considered reasonable, then they would not owe a penalty. And as with the coverage standards, the schedule doesn't create any requirement for employers or insurers to provide coverage at a price that's considered affordable. However, the Health Connector does align the schedule with the premiums that it sets for state-subsidized coverage through our Connector Care program, which serves individuals up to 300% of federal poverty. So on the next slide, we have our 2018 Affordability Schedule for individuals. And just To walk you through a quick example, if I made $40,000 per year, I would be deemed able to afford coverage that costs up to 7.45% of my income, or $248 per month. So if my job offers me a plan for $100 a month, I would be penalized if I didn't take it. But if I didn't have access to coverage at work and non-group coverage for me would cost $400 a month, I wouldn't face a penalty if I went without insurance. So moving on to the next slide, we have some information here about our penalties for those individuals who determined that they had access to affordable coverage but didn't enroll. And per statute, their penalty is set at half of the lowest cost Health Connector plan that's available to them. So we coordinate with our state's Department of Revenue to publish these penalty amounts as they're collected as part of the state income tax filing. And we do also have exemptions for short coverage gaps or financial hardship or religious conscience. But basically our approach to the penalty schedule has reflected the subsidized premiums that are available to individuals in the Connector Care program that we mentioned. So that results in a penalty schedule that's progressive with income. However, I'll note that a taxpayer may end up paying less than these amounts that you see here as the result of a policy that we enacted alongside the ACA that allows taxpayers to net out any federal penalty that they pay to avoid double penalizing a state resident who's also subject to the mandate.
Great. So next slide, which is a title slide, and then the next one. So just briefly, I think, a lot of individuals are, of course, aware of the primary reasons why, a state might be interested in an individual mandate, of course, encouraging coverage, which we all think is very important for both health and financial reasons, and sort of risk mix stability in markets. But over the last 10 years of administering a mandate, we've identified and leveraged other benefits, which we consider kind of secondary or indirect benefits of having a mandate at a state level. So just wanted to briefly touch on those, and certainly happy to take any questions later. So on the first count, the fact that we administer our own individual mandate here in Massachusetts means that we as a state have access to very detailed information about the health insurance status of our residents. And that's actually allowed us to partner with the Department of Revenue, who on our behalf as the state's exchange, which really drives outreach to those who need coverage, the Department of Revenue sends out mailings to individuals who are found on their tax forms to be without full-year insurance meeting Massachusetts' standards. So as you'll see on the side there, we send out information about the types of coverage people might qualify for. We use research and data from our state and from the remaining uninsured in our state to really drive what the key messages are that we think will be most impactful to those individuals who are without coverage in Massachusetts. So that's one of the ways we feel we've been able to benefit from the state-level administration of a mandate. Next slide. Another kind of secondary or outer bound benefit of having a mandate is, of course, that it provides an avenue for a state to really establish kind of a common benefits floor across market segments. So, of course, the Affordable Care Act brought EHBs into play for the non-group and small group market predominantly, although it had other interactions with other market segments. Using a standard like minimum creditable coverage, which Ed spoke about, has allowed us to promote certain features of coverage that we want to make sure that really everybody in the state carries. And so that's been an added feature for us to really promote the types of coverage we think are important. I think we found that to be very beneficial the whole way through. That was a big part of why we decided to keep an individual mandate at a state level in Massachusetts, because we liked that common kind of benefits floor. And I think particularly with conversations around the country right now about different potential changes to market rules, whether we're talking about association health plans or the like, having a tool like MCC at play in our market, even though it is placed on individuals and not employers or others, is a powerful tool for kind of normalizing a common benefits floor that we really value. Next slide. And then finally, just landing on the fact that the individual mandate is, of course, not designed to be a revenue generator. That's not its primary purpose in the Commonwealth, but it does generate revenue for the state via the penalties that are assessed to individuals who are found to owe one. Those funds go into a trust fund here in the Commonwealth called the Commonwealth Care Trust Fund, which was established alongside the establishment of our exchange. And those dollars go into this trust fund in order to support what we call state RAP subsidies. So our state uses those funds to help further bring down, further subsidize the cost of insurance for individuals below 3 times the federal poverty level. We do that in a program called Connector Care. There's other sources of revenue that help support that, but the penalty revenue is one of those sources that's used to help make coverage additionally affordable beyond what it would be just under the Affordable Care Act subsidies. And we feel that that's been a very integral and critical central part of why we've been able to achieve widespread insurance coverage in the Commonwealth. So I will end there, and we added additional detail in the appendix of our slides, which I understand will be made available so people can see more detail beyond what we were able to touch on just now. Thank you.
Thank you very much to our Massachusetts team. We really appreciate that information. I'm going to put another plug in for questions, but I'm also going to keep us moving, and we're going to move over to Stan Dorn, Senior Fellow at Families USA, who is going to talk to us about a Maryland proposal. Stan?
Thank you so much, and I want to thank all the folks at NASHB as well as our colleagues from Massachusetts and Jason. It's really a wonderful opportunity to chat with you all today. The end of federal enforcement of the individual mandate creates an opportunity for state innovation, not just to protect residents from harm, but also to affirmatively increase the coverage opportunities and access to care that people receive. Next slide, please. Working with the Maryland Citizens Health Exchange and many legislators in Maryland, we've been working on an approach that would do such innovative strategies. And what's distinctive about what we're working on in Maryland is to try to not penalize people, but use individual mandate enforcement as an opportunity to enroll young and healthy consumers into coverage, simultaneously shielding state residents from increased premiums that otherwise might result from federal policy developments, and increasing the number of people with insurance coverage. And I'm just going to briefly pick up on a point that was made by Audrey about the minimum creditable coverage requirements in Massachusetts, and just note that that's a very important piece of the puzzle, that it appears that the federal government may be authorizing association health plans to be sold to large numbers of residents who previously have not accessed them, and to have that take place in a way that puts them beyond the scope of much state regulation under ERISA. States could regulate solvency, but not much else. And so we see the possibility of state mandate enforcement and defining the scope of minimum credible coverage as being really a potentially very important tool states could use to safeguard their markets. So I'm going to put that aside, and for the rest of the presentation focus on distinctive features of the Maryland proposal that could certainly change as the legislation moves forward, but are the core vision that we're now pursuing. Next slide, please. What's distinctive about the Maryland approach is that the idea is to say, when an uninsured person owes money, let's do everything we can to help that person use the payment to obtain insurance rather than simply impose a penalty. Next slide, please. There are 4 distinct interventions that are part of the Maryland approach, and I'll talk about each one in turn and in chronological order: before tax time, at tax time, after tax time, and after coverage begins. But I want to just emphasize that these are modular to a large degree. Some are much simpler than others. Some are more complicated. A state could pursue 1, 2, or all of them. We're pursuing them all in Maryland, and I'll describe them all to you for your consideration. Next slide, please. The first intervention point is prepayment. So here's the situation. This could happen as early as November 2019. It's open enrollment. Someone, we'll call him Fred, has been uninsured this year. He knows he's going to owe a penalty when he files his next year's state income tax return. He'll owe roughly $700. Fred can avoid that by making a $700 prepayment now during open enrollment to sign up for qualified health plan coverage. And technically the way this works is that the prepayment amount that Fred makes during open enrollment is credited against the amount that he otherwise would owe on his state tax return. There would be a calculator made available on the exchange website to help people estimate what their likely penalties would be, much as the Kaiser Family Foundation now has a penalty calculator. But the goal is to promote the use of these dollars to enroll into coverage during open enrollment rather than wait and potentially pay a penalty. Now, I would note this is a relatively easy lift compared to some of the things I'm going to be talking about in just a moment. So this is something that a state with a federally facilitated marketplace could consider. Next slide, please. Now, why do we want to do this? Well, the goal is to change the consumer's perspective on enrolling into coverage so that enrollment seems like a more sensible option. Today, a lot of consumers think to themselves, well, I could pay a $700 penalty or I could pay a $1,000 premium over the course of the year. Which one is more? Well, duh, I'll just make the $700 penalty payment. We want to change that perspective to the following. I'm going to make a $700 payment one way or the other. It's either going to happen now for insurance or later just as a tax penalty. If I add $25 a month to that penalty payment, I can get insurance for it. Why not do that? And I think there's good reason to think this could change how consumers look at enrollment in a way that substantially increases the number of people who sign up for coverage. Next slide, please. So that's the first intervention, and for that, you just need to structure your state income tax rules appropriately and work with carriers to make sure that they're receiving payments. This next one is a heavier lift administratively, though the exchange in Maryland tells us that it's feasible. There would be administrative costs, but it's feasible. So here's the idea: in addition to the other aspects of individual mandate enforcement that play out in the state income tax return, a tax return in Maryland would ask 3 additional questions. 1, is anybody in your household uninsured now at tax time? 2, do you want to have us share the relevant information from your return with the exchange to see if that uninsured household member qualifies for low-cost or zero-cost insurance? And 3, if you do owe a penalty, check this box if you want to pay that penalty to the state and receive nothing in return. If you don't check that box, we're going to assume you're a normal human being and would rather have us hold that money for you and see if you can use it to obtain health insurance. So in cases where the consumer authorizes sharing the tax return information with the exchange would then determine eligibility for the uninsured household member for Medicaid, for CHIP, and for premium tax credits or PTCs in the marketplace. That would require the exchange to go beyond the information on the tax return, contact the household, and obtain information about, for example, an attestation of citizenship or satisfactory immigration status. In the case of Medicaid, an attestation of current monthly income, etc. In the case of PTCs, premium tax credits, the exchange would make sure the consumer knows that if they enroll with the aid of PTCs, those would be paid in advance and would need to be reconciled on their tax return, and that the consumer needs to keep the exchange informed of changes in household circumstances throughout the year. So if the exchange finds that somebody is eligible for PTCs, the exchange would then look to see whether at tax time there is a health plan available to that consumer at 0 additional premium cost. And by that I mean a health plan that's available where the premium is no more than the premium tax credits for which the consumer qualifies, plus the payment amount that the consumer would otherwise owe. If so, then the consumer would be enrolled. Now, this is a limit, obviously, on coverage options. And the reason why we have this limit is to maintain a difference between the open enrollment options and the tax time options. We did not want to create a situation where a healthy consumer at open enrollment could say to themselves, well, why should I sign up for insurance now? I can wait and see if I get sick by tax time. If so, I can sign up for the exact same options then. There may be other ways to preserve that distinction too, which we can talk about in the Q&A. But for the time being, the tax-based enrollment is enrollment into 0 additional costs, so that the consumer says, well, what the heck, either way, I'm going to pay the same amount, may as well get health insurance. Next slide, please. Now, largely because of the silver loading that's taken place in response to the end of CSR payments to insurers, there are more than 60,000 uninsured Maryland residents who have access to coverage that would be classified as zero additional cost coverage under the rubric that I've talked about. In urban counties where there's multiple carriers offering coverage, that is typically a bronze plan, albeit with some pre-deductible services. In rural counties with one carrier offering coverage, that is a gold plan available at zero additional cost. Next slide, please. Now, what happens if somebody doesn't have a zero additional cost plan available to them, or for whatever other reason they don't enroll into coverage at tax time? Their payment amount is then held in escrow, which is what you'd expect for a down payment, and reserved for use at the next open enrollment period, so that when the following open enrollment period occurs, the exchange would reach out to that consumer, or the comptroller, the tax agency here, would reach out to the consumer and say, look, we've got $700 of your own money sitting in your escrow account. You can use it during this open enrollment period to sign up for coverage. If you don't, that money is going away and you won't be able to benefit from it again. So this use it or lose it feature, we think, could be a behavioral prompt to enrollment that encourages people to sign up rather than flush their money down the drain. Next slide, please. A similar psychology operates in this fourth and final intervention point. Namely, after somebody is enrolled in coverage, we want to structure payments to the carrier to encourage continued enrollment. So this only does not apply to intervention point number 2 at tax time. It's just people who sign up during open enrollment using their down payment amount to go to the carrier and receive 12 months of coverage. So for such consumers, the prepayment amount, the lump sum amount that they make, is divided into 12 equal installments. And if the person disenrolls after March, the remainder of that money goes back to the state. Now, the idea is we want the consumer who's thinking about dropping coverage in March to say, if I drop coverage, I'm going to be flushing down the drain $500 of my own money that I've already spent. And although the sunk cost fallacy is called a fallacy by economists, it's something that a lot of consumers hold to, and we want to try to use that to help people stay covered. Next slide, please. Now, there are obvious limitations. A lot of people will not wind up getting coverage for many different reasons. They may get health insurance between the end of open enrollment and the filing of tax returns, or the filing of tax returns and the start of the next open enrollment period. There may not be a zero premium cost plan available to them, and they may not proactively enroll during open enrollment, etc. Lots of different reasons why. So we certainly are not going to be eliminating the payments that people make without receiving coverage, but we want to reduce them to a minimum. The silver lining of the fact that there will be such payments is that the bill proposes to use them to cover the administrative costs of the revenue agency and the exchange in implementing this proposal. And to the extent there's money left over after paying those administrative costs, the exchange could use those dollars to stabilize markets however it sees fit, borrowing a page from Massachusetts to provide wraparound subsidies for low-income people, providing reinsurance, additional help to application assisters to get people enrolled, etc. It will be up to the exchange to decide. Next slide, please. So in short, there seems to be a lot of appeal to this idea of moving away from a punitive definition of mandate implementation to one that uses required payments to enroll people into coverage. At this point, our legislation, it was introduced earlier this week, a majority, more than 50% of the Maryland House of Delegates is co-sponsoring the bill. Nearly 50% of the senators in Maryland are co-sponsoring the bill. So we think that we're obviously, many have slipped twixt cup and lip, in Benjamin Franklin's immortal words. And we'll have to see what happens as the legislation proceeds forward. But I think this is an exciting opportunity worth thinking about as a way to build on the successes of the ACA, but go even farther towards market stabilization and improved coverage. Thank you.
Thank you, Stan. We really appreciate that. I'm going to turn it over to Jason at this point, and he's going to walk us through some of the mechanics of how states could approach undertaking a mandate. Jason?
Great. Well, thank you, and thanks to NASHP for setting this up. Thanks to my co-presenters. We have been having many conversations about this, both in public forums and privately, and they have all been great to work with on this stuff and very generous with their time. It's great to be with you. I'm speaking here through my work with State Health and Value Strategies, which is, I think, another project of RWJ Foundation, so thanks to them. So I am here to talk to you about a particular approach that states can take to implement a state individual mandate, and there are different ones, but I think the approach that I have focused on is using the federal mandate as a model and a baseline, and sort of working from there, as opposed to sort of starting from the Massachusetts model or coming up with something new from scratch. And so why is that? So in broad outlines, the federal and Massachusetts model are quite similar. Both were implemented quite simply through the tax system. They have very similar definitions of qualifying coverage. Most major medical coverage applies. Similar sets of exemptions. Similar penalties that are 0 for very low income people and then grow as income increases and then hit a cap related to the cost of coverage. They both include reporting requirements for insurance companies that is relatively simple. Who in the family was covered for which month. Now there are some specific areas of differences, specific issues about what qualifies as coverage, the affordability rules for an exemption, the specific penalty schedule, the specific contents of reporting, and of course different terminology and procedures. And I do not want to claim to you that the federal approach is a better approach. And I'll say a little bit more about some specific differences, and the Massachusetts folks know a lot about it as well. And there are some points on which the Massachusetts model has some clear advantages. But I do think that for a state besides Massachusetts, there are important reasons to think about starting with a federal model. And the most important one, far and away, is that the federal individual mandate has been in effect for 5 years, and the implementation timeline for a state wanting to stand up its own mandate is short. It's 2019 is not far off, and even if a state wants to have a gap of a year and not have a mandate effective until 2020, even that's not so far off given the complexity of the undertaking. And of course, complying with new rules takes time for all the stakeholders, right? So insurance companies need to finalize their plan designs and have been building plans that comply with the ACA rules for 5 years now. Employers need to choose which plans to offer. Individuals need to understand how to comply. Tax preparers need to understand how to fill out forms. They need to build tax preparation software. Then on the back end, insurance companies and other coverage providers need to do reporting. All of these stakeholders have spent 5 years building systems and experience with the federal rules. They don't have experience with other rules. And so, again, standing up a whole new system would just simply be a lot more work and may not be possible at all for 2019. So that's, I think, the main reason to start with the federal approach. There are a couple others. It does simplify legislative drafting using an approach called conformity, which basically means that the state sets its law by reference to existing federal law as of a certain date, and that still allows certain specific changes. And I'll talk more about that later, but if there are specific elements of the Massachusetts model, or if there are specific additional rules like the ones Stan discussed, those can easily be accommodated working within the federal framework. It also simplifies incorporation of guidance. As this well-educated group knows, the ACA is a bit of a framework, and a lot of work has been done through regulations and other guidance to implement it, and many choices were made, and the federal guidance can be adopted similar to the federal statute in a way that will just save the state a lot of work and make sure it gets to workable answers quickly, and so that guidance can be sent to stakeholders in time that they need to comply. And then I think there are also some sort of strategic reasons for sticking relatively close to the federal model. It allows a state individual mandate to be described as sort of sustaining the status quo, keeping the ACA largely as it is, rather than imposing a new requirement, imposing something new, which of course invites relitigation and has winners and losers and all of those things that, as we know, can be a practical barrier to moving through a proposal. So that is the those are the reasons to do it. And so the basic approach, again, you start with a federal mandate, you incorporate the mandate itself and the guidance by cross-reference. Then you modify it for state context. So there are, and I'm actually, sorry, I'm back on that. Is that the right slide? That is the right slide. Sorry about that. So you modify it for state context. So that means things like the federal mandate has an exemption for the federal income tax filing threshold. Well, of course, you'd want your state mandate to use the state filing threshold. Or the federal mandate has an exemption, has a cap based on the national average bronze plan, you'd want to use the state average bronze plan, things like that. Then there are some specific policy changes, which I will get into, and then it can generally be implemented through a single line on the tax return. So let's go to the next slide and talk about key components. I won't spend much time on this because our Massachusetts friends already did a really good job of walking through them. So individual mandate, again, the key pieces of it are the definition of qualifying coverage, the exemptions, and the penalty calculation. The reporting requirement for certain coverage providers, I should talk about this a bit because I do get questions about it. So folks may be aware that the ACA included 2 reporting requirements, one for large employers, and that one is not at issue here, and then a much simpler one, frankly, for insurance companies and other providers of coverage. And it's basically a very simple form that says, this family, this coverage unit, these were the people who were covered and for this month of the year, or, check this box if they were covered for all 12 months of the year. So that requirement remains in effect at the federal level, right? So the federal tax law, as you know, repealed the mandate penalty. It did not change this reporting requirement. So insurance companies and others are still required to send this reporting, but they are not required to send it to your state. They are required to send it to the IRS and to individuals. So, it's part of the goal here of sort of having the minimum possible effort that stakeholders in your state need to do. I think, the basic idea is that reporting that they currently send to the federal government, they would send to your state Department of Revenue or whatever agency it is in addition. Then, the current requirement already requires it to go to the individual. If an insurance company is already sending this federal form to the individual telling them they have coverage, they don't need to send a second copy of it. So, really the only sort of incremental effort here would be take the federal reporting that's going to the IRS and send it to the state as well. The next thing is procedures for granting hardship exemptions. So under the ACA, there are certain exemptions for hardships and religious conscience that are granted by the marketplace. The thinking was that IRS was not sort of uniquely well suited to grant those exemptions. So the model legislation I put together includes provisions for providing that the state marketplace or Department of Health would carry out that function, although it could certainly be the state revenue department. And then notification of uninsured about coverage options. This goes back to what Audrey was talking about how Massachusetts has used the data it has received under the mandate to do outreach for coverage. The federal law, the ACA actually includes a similar requirement on the IRS. The IRS has not done a great job to date of carrying out that provision, but a state that has its hand on these data could use it to do a lot of good things. So next, and I think last slide. Yes, okay, so let's talk about potential changes to federal rules other than the ones, of course, that Stan mentioned. So I think one is addressing substandard plans, and I think the previous speakers have addressed this to a great extent. There may be substantial loosening of federal rules on things like association health plans that could hurt state markets, and it is straightforward within the definition of qualifying coverage to say that association health plans only are qualifying coverage if they satisfy the market reforms that they should, et cetera. So the model legislation includes suggested language for how to deal with that. Interaction with the federal mandate penalty. I think Massachusetts friends talked about that as well. While the federal mandate is gone, it could theoretically come back. Who knows? But it certainly does not hurt to include a provision saying that if there is a federal mandate penalty, then the state penalty is reduced by the amount of the federal penalty. And then changes to penalty amounts and exemption rules. This gets very specific, but as we discussed, there are slightly different schedules for how much the penalty is and how the affordability exemption works. And so, all of that is dialable. A state could readily adopt Massachusetts rules or some other rules for that stuff, and none of that would sort of create the big implementation challenges that it would if you were to, totally replace the federal system with something else, because of course for insurance companies developing coverage right now, et cetera, the specifics of the penalty amount is not something that they need to worry about. So I know we want to have time for questions, so I will stop there and turn it back over to our moderators.
Great. Thank you so much. Thank all of you. We really appreciate your presentations, and we do have questions that have come in through the chat. So we will start working through some of these, but I encourage others to post their questions. This first one is specifically for Massachusetts. Can you all describe what you consider reasonable access to coverage? That was something that was noted in your slides.
Okay. Sure. So the affordability schedule has developed over the last decade or so, but it was generally started to try to triangulate kind of what was available in the market in terms of prices that people were paying for coverage and what budgets that particular incomes might allow for in terms of available income to spend on health insurance. And we've maintained a fairly stable approach since that original development. For the up to 300% of federal poverty level, we're using the premiums that we're charging in our Connector Care program as those affordability standards. They're aligned because we think that it is practically affordable, subjectively affordable for people to pay that and enroll in coverage because people do so and seem to maintain their coverage okay. And then above 300% post-ACA, we've been using the federal affordability standard as our cap and then kind of creating a glide path, so to speak, between 300% and 400%, where there are slightly higher than the subsidized but lower than the federal cap percentages of income that are considered affordable.
Thank you very much. And a related but different question, how are dollar amounts determined for penalties? And this specifically is directed towards Massachusetts and Maryland. And just one of the sub-questions here is, have insurers been involved, I'm assuming health plans, in discussions of setting premiums and penalties?
So just speaking for Massachusetts, on penalties, it is a formula that's half the cost of the lowest cost connector plan available through the exchange, the Health Connector available to you. So that will vary by your income. If you have access to a subsidized plan, for example, that will vary by region of the state, age, et cetera. So that's how that works. And just with respect to carrier involvement, since the beginning of the connector as an entity in health reform in Massachusetts, we've worked very closely with the carrier community as well as consumer advocates and employers and sister agencies and others. So carriers have always kind of been in the mix, but specifically with respect to penalties, that's set out in statute.
Thanks. And in terms of Maryland, the approach that we're taking in the bill is that the penalty amount that people would pay is exactly what it is under federal law. No one would pay a penny more. But we're defining the affordability exemption more broadly, taking a page from Massachusetts' progressive approach. The amended version of the bill that we hope to move forward with in committee would say that people with incomes up to 138% of poverty, the Medicaid eligibility threshold, would be exempt from any payment requirements requirements, which is different than the current federal provision of federal income tax filing penalty. And then between 138 and 250% of poverty, we would gradually phase up to the federal 8% affordability standard. So no one would pay more than under federal law, and we would create exemptions for low-wage working people that we think are more realistic in defining affordability.
Great, thank you. And just another, I hope, sort of quick follow-up for the Maryland proposal. Stan, do you know, is it getting bipartisan support right now? You mentioned that there were co-sponsors in a number of co-sponsors in both the House and the Senate. Are those co-sponsors of both parties?
Not yet. We're still working on getting Republican co-sponsors. Unfortunately, they're just Democrats. The Republican governor in Maryland, has not come out with a position. Although the exchange has been helpful in providing technical advice, they have been careful to make clear they don't have a position on it. But we're early on, and we're hopeful of getting bipartisan support.
Great, thank you. So this question is, I think, more directed towards Jason, but welcome others to weigh in. Were there any trends that have been observed from tax data on specifically who has been paying penalties? And so that sort of broader question, I'm assuming, is under the current federal ACA mandate. But I imagine that Massachusetts could weigh in as well. Jason, do you want to start?
Sure. Yeah, it's a great question, because I think one ground for criticism that the ACA individual mandate received was that it was paid to a substantial extent by low-income people, including people with incomes so low that it really appeared that they should have been exempt under one of the various exemptions that the ACA makes available. And so, so there is sort of a cautionary tale about those data that the IRS released. So when I was at Treasury and we were implementing this provision, and the data started coming in on 2014 by income of who had paid the penalty, we were all, frankly, surprised and disappointed to see that indeed low-income people were paying it to such a great extent. And what we discovered as we pieced things through is that there was a lot of confusion and a lot of accidental overpayment. And I apologize for saying this, but it was because we had actually just not made the forms and instructions clear enough so that people who were eligible for exemptions were able to knew that and were able to take the exemptions that they should have taken. So there was a whole effort that we undertook to work with tax preparers to get tax preparation software developers to change it. We changed our forms and instructions. The IRS also did direct outreach to people who they could identify as having overpaid, saying, hey, please consider amending your tax return without paying this. And in some cases where it was very clear, the IRS even sent people checks directly without even getting them to amend their return. Now, unfortunately, the data that have been released do not reflect any of those efforts, and we don't have the tax year 2016 results, so we sort of can't see how much an improvement there has been along those lines, but I am certainly hopeful that our efforts have borne fruit. And I think this is also an important message to states, and this isn't something that really has to go in your legislation, but certainly when the rubber hits the road and you get to actually implementing this, you want to certainly make sure that all of your guidance and materials and forms and instructions are very clear, so you don't end up with people paying the penalty who don't actually owe it.
And I'll just add, this is Audrey from Massachusetts. We do study the data from the individual mandate filings to try to understand the demographics and kind of contours of those who are without coverage. And they mirror what you might expect with respect to kind of who tends to have or not have coverage. So we know that the uninsured are much more likely to be male. They're much more likely to be under the age of 40, more likely to be lower income, and to be single filers, not filing married or with dependents. And so that kind of squares with other, research and data we have about the uninsured, but we do look at that closely.
Thank you so much. And Audrey, sort of related to that, how has the mandate affected uninsured rates in Massachusetts? So a subtext to that question is the public aware of the mandate's existence? Is that something that has helped, from your perception, get people insured?
Yes. So this is a great question. I'll try to be brief on it because I think we could probably talk about it forever. But I think that in Massachusetts, we believe, and there's a consensus, that the mandate has been an integral part of our success in expanding coverage. However, it's difficult to tease out because the state did so many kind of forward-leaning things all at the same time with respect to expanding coverage, inclusive of the individual mandate. The same year, the state launched a program for low-income people who had a little bit too much income to be in Medicaid through the exchange. So we made subsidies available to the very population we knew was most likely to be uninsured. There were new incentives that came into the mix for employers to offer coverage. There was widespread, public awareness campaigns and advertisements about the exchange and other kind of market reforms and consumer protection. So there was just so much attention and noise around expanding coverage, and we did, in fact, expand coverage. Of course, Massachusetts was starting from a place of a higher level of insurance than you see nationally, but we do see it as sort of part and parcel of what that success was really built on here. Now, and so I think in those first few years, there's no question people knew about it. There hasn't been recent polling data collected on the mandate, either awareness of it or support for it. In the appendix of the slides that we pulled together, we do have the most recent polling data we have about public awareness and perceptions, but it's from 2014. So frankly, we're about to go on this journey right now in Massachusetts of wanting to ensure that there continues to be widespread awareness of the state mandate, since for the last few years maybe there's been more attention to the federal one, and if people hear the federal one has gone away, we want to make sure they understand there's actually something underneath that that's very important and very specific here in the Commonwealth. So we're, I guess, about to find out how much people do remember it and are aware of it as a standalone policy.
Great, thank you. And then let's direct this question towards our national experts. What are the challenges to establishing a mandate in a state that is using the federally facilitated marketplace? Both of the states that we've been talking about as examples today are states that have their own state-based marketplace. Are there differences for those using the FFM?
So I'll start. I don't think there are any substantial challenges. If you look at how the individual mandate has worked at the federal level, the state-based, the FFM, the federally facilitated marketplace, does grant exemptions to people who come in. So I think that's the one role that some other state agency would need to take on, and I think that could either be done by the state revenue agency, which I think actually is in Massachusetts. Some of that happens, or it could be done by the state health department or the state insurance department, or really any executive agency should do that. Then there are other functions like defining what qualifies as coverage in addition to the things enumerated in the statute. Again, the state insurance department or some other agency would be well qualified to do that. So in sum, I don't think it's materially harder to do it in a state with a federal marketplace.
In terms of the Maryland approach, as you recall, there were 4 different intervention points. And in my view, interventions 1 and 4 could be done in a federally facilitated marketplace state, an FFM state. 2 and 3 would be kind of difficult. So the first intervention was prepayment, where an amount that I paid during open enrollment can be credited against whatever I would owe on my state income tax return. One could do that in an FFM state. The state would design the tax return and the tax return laws accordingly. The state would need to work with carriers to make sure that they're equipped to receive lump sum payments and to credit them appropriately. unfortunately, but I think that would be doable. And the fourth intervention was simply when someone enrolls in a plan expecting year-round coverage based on a lump sum payment, divide that lump sum payment into 12 equal increments so that the consumer is incentivized to retain coverage. So you could do that in an FFM state. The other interventions require an exchange to step in and at tax time determine eligibility for PCCs, and that would be hard to do with a federal marketplace. You could maybe do Medicaid enrollment at tax time, but that's you have your state Medicaid agency you could work with, so that's an option too. But really the prepayment option I think is the most viable one for an FFM state.
Great, thank you. So one of our questions is related to the importance of the strength of a mandate. So if the mandate is out and if people understand it, but there is the actual enforcement or the penalty is not as strong, is it still valuable? So is it the mandate itself that is the most important piece, or is the penalty also equally important?
Yeah, go ahead, Jason.
No. You go ahead. I think the Massachusetts experience is actually probably the most relevant piece here.
Yeah, it may be. I think this might be one of those places where I think the force of a mandate paired with other types of affordable coverage and things that people find valuable independently, all tie together to make a statement and make people aware and kind of drive a normative action. In Massachusetts, because the penalty amount is inherently less than the cost of coverage, my personal sense, and we can think about research sources on this, but my personal sense is that it's more directionally influential to people than a specific math question. But I welcome thoughts from my colleagues or Jason or Stan on that one.
I guess I would just add that I think there is pretty clear evidence that the federal mandate increased take-up in Medicaid among people who are pretty clearly exempt from it. Now, some of that may have resulted from what I talked about before, of people not knowing that they were in fact exempt from the mandate. But my understanding is that the evidence both among the Medicaid population as well as among others who are potentially exempt is that there does seem to be a factor there. I don't think you could sort of say it's one or the other. I think that both help, and I think one thing to keep in mind is I think people are often pretty vague about the specifics of tax rules in general, and so it may be more important that there is some penalty than the specific size of the penalty or even exactly whom it applies to.
So this is Stan. I'm going to slightly disagree with my colleagues on this point. That there are a lot of folks, economists and others, who believe that one reason why take-up has been relatively low nationally in the marketplaces is that the penalty amount is relatively small compared to premiums. And there's some anecdotal evidence suggesting that people really do make that comparison I was talking about. How much am I going to have to pay in penalty? How much am I going to have to pay in insurance? And we're trying to shift the framework so that people think about, well, I have to pay the penalty anyway. What's the incremental cost of coverage? But I do know, there's a lot of economists. I'm not an economist. I'm a mere recovering lawyer, but I've worked for economists, and I'm quite sure that if we had a standard economist on the call, they would say that the size of the penalty matters, that incentives matter, and if you want a healthy marketplace, you shouldn't be weakening the amount of the penalty.
Great. Thank you all. We are just at time, so I know everybody is very busy. I'm going to wrap us up with a huge thank you to our speakers, A thank you to our audience for very thoughtful questions, and to our staff here that pulled this together. We truly appreciate your time today. We do have a quick survey at the end that we hope you will respond to, so that we can be sure that future webinars meet your needs. And with that, I hope everybody has a great afternoon. Thank you all.